My presentation is also a little bit on pathophysiology, not only on monitoring. I will talk about some mapping experiments that we did the last years in Maastricht, and mainly on the substrate also of patients with paroxysmal atrial fibrillation. So what do we know? Based on the studies of Alessi and de Groot, we know that the substrate of long-standing persistent AF is highly complex and characterized by electrical dissociations between the atrial bundles, so longitudinal dissociation, and a high incidence of epicardial breakthrough. And for those who don't know yet, epicardial breakthrough is a wave that you see in your mapping array that's emerging, and you can't explain that by peripheral wave or other previous activity. Now, regarding the substrate of paroxysmal AF, not so much is known. It has been reported that longer signal average P wave durations has been seen in PAF patients versus control. And also that there was an increased dispersion of refractoriness in PAF patients versus control. And also ablation at sites of high dominant frequency slows and terminates paroxysmal atrial fibrillation, but not persistent atrial fibrillation. And finally, Koyojoyo published a study where he showed that the substrate of paroxysmal AF and persistent AF is caused by slower of right atrial conduction, lower refractoriness, and atrial dilatation, but that persistent AF is only associated with structural remodeling and no further electrical remodeling. As you can appreciate in this figure in the data that Maurits Alessi published, you see that in patients who have never had episodes of AF and where AF acutely was induced during cardiac surgery and mapped, that those patients show low complexity patterns of atrial fibrillation with 1, 2, or 3 waves, which you can appreciate on the left side. So the waves are color-coded, and those are broad waves homogeneously spreading over the mapping area. While in persistent AF, much more waves are simultaneously present. There is much more conduction block, and there is also more epicardial breakthrough occurring, which is depicted by the asterisks. To zoom in a bit on those epicardial breakthroughs, which are believed to be due to transmural conduction, here you can see on the right side that in the right atrium during acutely induced AF, there is only a small amount of epicardial breakthroughs occurring. So these are depicted by the magnitude of the asterisks. And on the right side, you see persistent AF, where much more of those epicardial breakthroughs are occurring. So we performed as well epicardial mapping during cardiac surgery. This is the electrode we used. This is a 256 electrode point electrode with an inter-electrode distance of 1.5 millimeter. With this electrode, we recorded unipolar electrograms, which we believe reflect more local activity than bipolar electrograms. We applied this electrode on the right atrial free wall and between the pulmonary veins in the oblique sinus. This is a surgical view of the procedure seen from the head of the patient. As you can appreciate, here is the right atrial auricle. Here is the mapping electrode positioned on the right atrial free wall. Here you see the aorta, and on the right side you see a movie where we are mapping the free wall of the right atrium. The patients included in this study were patients with acutely induced AF, so no prior history of AF, which was checked with monitoring. Those were 11 patients, 12 patients with paroxysmal AF and 9 patients with persistent AF. The patients with paroxysmal and persistent AF were slightly older, and patients with persistent AF had a higher incidence of stroke and had higher left atrial size and left atrial volume, as you would expect. Next, I will show you real-time time activation maps of the electrical activity mapped during cardiac surgery. So on the left side, you see a map of acutely induced AF. You see here that the activity is still irregular. You have broad waves which are entering the mapping area and spreading homogeneously. And there is also some pause between the electrical activity. On the right side, you see now a movie during persistent AF. As you can appreciate, the activity is far more complex. The waves are only sometimes 1.5 millimeter broad. There is much more epicardial breakthroughs occurring, and there is almost continuous electrical activity. In the middle, you see the movie of a patient with paroxysmal AF, and here you see that there is less complex activity. It seems to be less complex activity than persistent AF, and also broad waves appearing, but of course, by visual appreciation of these movies, it's difficult to deduct any conclusions. That's why we also analyzed all those data. And here you see the AF cycle length in the left upper diagram. So patients with paroxysmal AF had a higher AF cycle length than patients with persistent AF, and the conduction velocity was lower in patients with persistent AF compared to patients with acutely induced AF and paroxysmal AF. But more interestingly, the number of waves was much higher in patients with persistent AF compared to acute and paroxysmal AF, and there was no difference between patients with acute and paroxysmal AF. Also, number of waves was higher in the left atrium compared to the right atrium in patients with persistent AF. The same holds true for the number of breakthroughs. So the epicardial breakthrough events, they were higher in persistent AF, higher in the left than in the right atrium, and no difference between acute and paroxysmal AF. And the fractionation index, which we analyzed based on unipolar fractionation, was higher in the left atrium in all three groups, and also only higher in persistent AF compared to acute and paroxysmal AF. Here you see the AF complexity measured as fibrillation waves per second, and it's plotted in a box plot. And as you can appreciate, the AF complexity is as well in the right and the left atrium higher for patients with persistent AF, but the spread of AF complexity is highest in the paroxysmal AF group, indicating that in this group there is a high difference between patients with lower complexity and patients with higher complexity. To further analyze those groups, we performed structural analysis. We excised the right atrial appendages with all the limitations, of course, because there are right atrial appendages. And we quantified cell dimensions in this histological slides. And we found that in persistent AF, the cell diameter and the cell width was higher than in acute AF, but no correlations with AF complexity, so these cell dimensions did not correlate with the number of fibrillation waves per second. Then we analyzed fibrosis, total amount of fibrosis. We used here, therefore, a Cyrus red staining. You can see representative pictures for acute AF, paroxysmal, and persistent AF. As you can already appreciate, persistent AF seems to have more fibrosis overall than acute AF. However, when we quantified it, there was a trend towards more fibrosis in persistent AF. However, this trend was not significant. And when we correlated this data to the waves per AF cycle length, so correlation to the complexity of AF, we saw that there was no correlation at all between fibrosis and AF complexity. Then we analyzed the gap junctions, which are the cell-to-cell connections. We analyzed connexin 43. And here you see those representative figures. In acute AF, the coupling is at the transversal side from cell to cell, while with paroxysmal and persistent AF, there is more lateralization of those connexins 43, which is pro-arrhythmic, or can be seen as pro-arrhythmic. And if we quantify these gap junctions, we see that in persistent AF, the lateralization is higher than in acute AF, and the CX ratio, which is in fact the polar divided by the lateral, is higher in persistent AF than in acute AF. And this holds also true for the paroxysmal AF group. So there seems to be more lateralizations of connexin 43 in those two groups. However, when we correlated this to AF complexity, there was no correlation. And finally, we quantified endomesial fibrosis. Endomesial fibrosis is the fibrosis between the atrial bundles. I don't know if maybe Dr. Verheulen also talked about this morning. So not overall fibrosis, and we believe that this fibrosis is more important than the overall quantified fibrosis. Here you see the results. So in persistent AF, there seems to be more fibrosis, endometrial fibrosis than in acute AF. Again, this was in analysis not significant. The p-value was 0.054. And when we correlated this to AF complexity, there was a correlation between endometrial fibrosis and the complexity of atrial fibrillation. Finally, the fractionations that we quantified, which is depicted here. So here you see a representative trace. In green, the true or intrinsic deflections are identified, and all the smaller deflections, which are depicted in red, which we believe is the surrounding activity. Those red deflections are divided by the true deflections, and this gives a degree of fractionation. If we correlated this fractionation to AF cycle length or to conduction velocity, there was no correlation, but this unipolar fractionation correlated very well with AF complexity, again expressed as wave per seconds. So, ladies and gentlemen, and Mr. Chairman, in conclusion, I would like to conclude that there seems to be comparable substrate complexity in patients with paroxysmal AF and patients with no history of AF. Those are, of course, patients who undergo cardiac surgery, so they are not suffering from lone AF. The spread of AF complexity seems to be largest in paroxysmal AF, meaning that maybe there a tailored approach may be more beneficial. Overall amount of fibrosis, which is used a lot, seems to be in our data set not a good marker of AF complexity. However, the occurrence of endometrial fibrosis seems to correlate much better with AF complexity. And from this comparable substrate complexity analysis, we can say that our data support the role for triggers in the occurrence of paroxysmal atrial fibrillation. I would like to thank you for your attention. These are all the people that collaborated in this research. And if there are any questions, I would be happy to answer them. Thank you.
Thank you very much, Bart. Are there any questions? Yes, please.
Yeah, Bart, excellent talk. I just have first a comment and then some questions for you. But I mean, I think it's from your data, because you just looked at the right atrium, I think it's really probably not accurate yet to say that there isn't a relation between fibrosis, because we'd all say that in most part, atrial fibrillation is a left atrial disease, particularly posterior left atrium. You measure the right atrial appendage, which may have misled you. Have you looked at any other way to quantify fibrosis, either by biopsying the left atrium, if you happen to be doing in there for some other reason, or with MRI or other techniques that could correlate your complexity with fibrosis? And how do you look at going forward with that?
Yeah, thank you for your very important question, Dr. Damiano. I agree, it's right atrium, it's not left atrium. We had a few patients who underwent also MACE surgery, so in which we had left atrial biopsies, but they were too little in this small data set to be able to tell something about the relation between fibrosis and AF complexity. We did not perform MRI study, so that might have helped. However, I think that there are more data emerging that left atrial fibrillation might be, in some cases at least, a biatrial disease. And when comparing specifically, because we also did left atrial mapping, but when we compare specifically right atrial mapping data with the histology, we also did not found, well, it's of course not also not approved. But we also didn't find any correlation. We are thinking of sampling left atrial biopsies, but it's quite tricky, because if you have a patient who is referred for cabbage and you're gonna staple the left atrial auricle and he has a bleeding on the intensive care unit, well, I don't have to tell you, you're much more experienced than me, then I think, well, it's very hard to explain to the family of the patient. But we're thinking maybe combining a clip and a stapling device. So the clip as an occlusive device for the left atrial, and then a second suture line, which maybe gives us a nice biopsy. But for sure, that's the way to go. Those right atrial data are, of course, not 100% representative. Yeah.
Was there any correlation between the amplitude of your electrograms and fibrosis levels? Just wondering, you know, one of the things we've been looking at is using body surface mapping and just looking for low voltages as maybe an indication of fibrosis, and that would be less invasive. I don't know.
Yeah. So we have body surface maps of all those patients. Of course, only in the patients with persistent AF. But we could for sure do that, and we are doing much more body surface maps in Maastricht. So that's a very good suggestion. Yes.
And then finally, I'm sorry.
No.
I assume some of the patients were coming to surgery for other reasons than their atrial fibrillation. And
yeah, only 2 were referred specifically for atrial fibrillation.
And could that have confounded your results? Because, you know, a bunch of people have shown, for instance, mitral disease can lead to atrial fibrosis, and even we've had earlier talk on ischemia leading, potentially ischemia being an etiology, and could that have confounded?
Yeah, of course. We chose to include patients with different underlying structural diseases to have the whole spectrum. We did an analysis to see if the surgeries were different between the groups, and that was not the case. So it was not randomized, of course, but there was no difference. It was not that the persistent AF were all mitral valve disease and the paroxysmal AF were all CABGs. So it was equally divided, but of course, as I tell again, it's a small data set, so those things could have influenced the results, yes. But on the other hand, we did find this correlation between the endomesial fibrosis, and so I think if we would have larger patient data, maybe we would have more clear results. I agree with you. Yeah.
Isabel.
Thank you for your very nice presentation. I enjoyed it very much, and I was impressed by the lack of difference between those with acute AF, so no prior history of atrial fibrillation, and those with paroxysmal atrial fibrillation. And I know you, together with Uli Schotte and others here in the present, are also involved in monitoring those patients after their cardiac surgery. Maybe you will tell us a little bit about that and what your idea is, because those patients also have probably vascular disease, coronary disease, mitral valve disease, hypertension, are elderly, so they are also at risk for atrial fibrillation.
Yeah. So that are data of my colleague Elan Bidar. But those were mostly patients with sinus rhythm at the time of operation. So,
but it were also the patients, the acute AF patients were also sinus rhythm patients. And my impression was they also have seems to have possibly a substrate. For the occurrence of atrial fibrillation.
So I don't know. Maybe Uli can comment, but I don't know the outcome of the data of Elan so far.
Are also moderate risk patients, probably?
Yes, they have at least an indication for an open chest surgery, so they are not healthy patients. And in many of those patients, we found paroxysms of atrial fibrillation in the not only in the direct postoperative phase, but also during 1 year after the operation. Which means that there will most likely be, to some degree, a substrate for atrial fibrillation in a normal patient in sinus rhythm undergoing open chest surgery. That's very obvious.
And the issue, the importance, of course, is that those are possibly at risk for a stroke, and then you will anticoagulate them.
Exactly, so that was one of the reasons why we started this project, to monitor for atrial fibrillation in the longer postoperative phase. And in fact, this policy already led to some patients being on anticoagulants after AF was detected in those patients. That's right, yeah. Any further questions? I would like to comment briefly on your questions about the fibrosis and the right atrial as the atrium we investigated. Of course, if atrial fibrosis is a determinant of atrial conduction disturbances, one should expect that there should be such a correlation also in the right atrium, even though atrial fibrillation very often is in fact caused by the left atrium. The fact that we did not find this correlation between AF complexity and atrial fibrosis, overall atrial fibrosis, I must say, I think is meaningful, because it means that an overall quantification of atrial fibrosis may not really unmask the aspect of atrial fibrosis we really have to look at if we want to really identify the aspect of structural modeling responsible for conduction disturbances. That was one very important the rationale behind this study. The fact that we found the correlation with endomusial fibrosis but not with overall fibrosis means that it's really the endomusial fibrosis which is important here and not the overall fibrosis, and that is meaningful for the imaging approach, we believe. Okay, any further comments or questions? Okay, this is not the case. Then I would like to thank you again, Bart, for your presentation.